Hi, I'm Dr. Rob Silverman, Amazon best-selling author of Inside Out Health and host of Proven Health Alternatives. Today's guest, Dr. Loren Marks, has 35 years experience as a chiropractor and over 30 years as a functional medicine elite practitioner. He talks about one of the most topical concerns today, SIBO, Small Intestinal Bacterial Overgrowth. He's going to break down the different types of SIBO, what SIBO is, what nutritional protocol, lifestyle, and diet protocols you need in SIBO, and what's the best test for SIBO. This is a can't miss listen podcast. Hey everybody, Dr. Rob Silverman here, host of Proven Health Alternatives, good friend, elite colleague, Dr. Loren Marks, chiropractic brethren, Diplomate in nutrition, just took a huge course in SIBO. This guy's got 35 years of clinical experience. Dr. Marks, how are you today?
I'm great, Rob, and it's a pleasure to be here and share some great information on people that really need to know more about this subject.
Absolutely. I'm happy I could get some time because I know you're like the leading expert now in the Northeast, at the very least, in SIBO. So tell everybody a little bit about your background and how you got to start integrating nutrition and how you became so integrative and you broke the silos of your specialty.
Interesting question. You know, I was always interested in nutrition, and even in college, I had taken initial courses there. And then eventually I decided to become a chiropractor. And, you know, we have a certain amount of courses of nutrition in chiro school, unfortunately, as opposed to medicine for the 1 hour. But, you know, it would make sense that would be an allied field in chiropractic. And but I always had a greater interest in that. And then I was always interested in things like applied kinesiology, which was really, I would say, the footing for all of this, because even though that's a muscle response testing technology, you begin to learn the application of nutrition to the human body and organs and muscles and so forth. And so, you know, it developed that way. And then many years later, I had met a doctor that had his own technique that was unique called contact reflex analysis. And I ended up, after 6 months, I was on fire with the work, and I started to teach with him. And we went all around the country for literally 15 years teaching the application of clinical nutrition through a modality like that. And then all of a sudden, this whole emergence of a science background came about in the field of nutrition that correlated amazingly well. And then the whole concept going from integrative to functional medicine, you know, became the way, looking at root causes and looking at lifestyle, nutrition, behaviors, diet. All of these things are, you know, this is the forefront of where we're moving toward. And thank God we are, because the current model clearly does not work except for acute care.
Without question. It only does acute care. And it's great about the root cause resolution, looking at the systems and not the symptoms. And we're both chiros, and, you know, we still have our chiropractic origin. We do that mechanical, but we're adding the biochemical. Lifestyle is everything. So
Absolutely.
One of the biggest topics now, and, you know, I like to call it more functional nutrition than medicine, because not everybody who partakes in it does medicine. So what is SIBO?
Okay. So this is an acronym, and it stands for Small Intestine Bacterial Overgrowth. It's when there is an abnormal number of bacteria that grow in the small intestine, of which there should be a very small amount in there. So there's 3 different parts of the small intestine. The first part of it should pretty much be not sterile, but the amount of bacteria that exists in the proximal portion of the small intestine is little to none. And then it advances, it gets a little higher when you get to the middle section. And then in the last section, or the distal section, there is, it starts to pick up speed in terms of the volume of bacteria, but yet it is still a small amount. The interesting thing is that what's called the biomass, or the maximum amount of bacterium that live within us, lives in the large intestine. And So much so that they've measured it and believe that it is approximately 100 billion organisms that live in the large intestine. Now, to differentiate that and define better what SIBO is, it is when the small intestine bacteria become more like that of the large intestine, then we have the condition called SIBO, right? And so a lot of people think that they're pathogens, and pathogens are bad guys. They're the foreigners, right, that can make us sick if we're acutely ill from an infection. But the bacterial overgrowth that occurs in SIBO is not the bad guys. It's an overgrowth in the wrong place. And so the terminology for that is called a pathobiont, right, which just means that there are too many in the wrong place of normal inhabitants, but yet they will make you sick and they will cause what is commonly known for most people as irritable bowel syndrome, or IBS. As a matter of fact, 60 to 80% of all IBS cases are due to SIBO, right?
Interesting.
And the problem arises from all this is that the bacteria ferment the starches and the fibers into gases that damage the small intestine and cause a lot of symptoms. And so that's what SIBO is in a nutshell.
So the large intestine really has a tremendous more, hundreds and hundred times more of bacteria. One of the big takeaways, most people think small intestinal bacterial overgrowth mean pathogenic bacteria in the small intestine. You really clarified it. It just meant too much volume. Small intestine is supposed to be a very small amount of bacteria.
Correct.
And now it's interesting that, you know, when we say small intestine, it's so long, it's sort of a misnomer.
Correct.
But maybe they did it on the size and they got it wrong in the diameter. But maybe they were smart, and maybe they're starting to think about the amount of bacteria. So there should be a small amount of bacteria in the small, large in the large.
The length of the small intestine is much larger than that of the large intestine, but the diameter of the small intestine is smaller. That's what they call it, small. Yeah.
So you got 60–80% of IBS, irritable bowel syndrome. It's
right.
Which is typically in the large intestine.
No. 60 to 80% of patients who have IBS is due to small intestine bacterial overgrowth.
Okay, I wanted to get that straight. It's due to SIBO. So if I'm a practicing doc and I'm testing for SIBO, I better also check for IBS.
Right, but but you are. Like, in other words, when a patient presents with the symptoms, and what are the symptoms associated with it? So, because that would lead you clinically into, wait, maybe this person has this disorder, all right? So you're looking at bloating is probably the number one symptom that people are going to present with. And then you have constipation or diarrhea or a combination. You have abdominal pain, belching, reflux, flatulence, various degrees of all this. Some people can have nausea. You can have leaky gut syndrome symptoms, like patients present with rosacea and rashes. So you could see that you will have a core thing of people complaining of gastrointestinal symptoms, but there are times when the only indicator is what's called extraintestinal, which means that the manifestation is outside of the gut, all right? So like your patient comes in, Mary comes in, and she's got these red, rashy cheeks, and she's had it for a long time, but she doesn't tell you or put together that it could be coming from her gut, right? And then, you can go down that whole path. Now, leaky gut is a whole nother subject matter. And a lot of people, and especially if you go on all of these SIBO sites where people have joined the communities and so forth, I always see people writing, does SIBO cause leaky gut, or does leaky gut cause SIBO? So the answer that's very succinct is SIBO can cause leaky gut, but leaky gut cannot cause SIBO.
So SIBO can cause leaky gut,
right.
But leaky gut can cause SIBO.
Correct.
Now, how would you differentiate? I think you kind of said how you would differentiate it with the extraintestinal issues via leaky gut versus SIBO.
Right, because you're going to see some type of manifestations. But I mean, look, these things are mixed. But the point is that most people who have SIBO will have gastrointestinal symptoms, the majority of them. Like yesterday, I had a patient come in who I've known for a long time. And I was asking her questions, and I said, "Do you bloat?" And she said to me, "All the time." And I was like, "Really?" I said, "Is it after meals?" And she said, "Yes, almost all the time." Now that's a hallmark right there. I said, "Do you have constipation or diarrhea to any degree?" "No." But yet she has bloating as a primary. She says so much so, and this is a woman who's about 70 years old, but like today, people like to look good in their, even depending on their age. And she says, that cool sculpting thing and all that, I went and had 2 different ones done, and it did nothing for me. And I said, she says, "Man, I'm still bloating." Yet she didn't put together that the gut problem is what's causing distension of her abdomen, and that it has nothing to do with fat around her midline. So of course it didn't work. So it was very interesting. But nevertheless, the point is that small intestinal bacterial overgrowth really is quite problematic. And as it goes on, and people are not diagnosed with it, other manifestations start to occur, because your small intestine is where your absorption of nutrients takes place. So, if somebody who has an acute onset of it, clearly they're just going to have all this discomfort in the GI system. They're going to go see someone. If you go see a gastroenterologist, which is usually where a lot of people would start after they see their primary care doctor, they send them to a GI doc, and then typically the more invasive methodology will start, because they want to make sure that they're ruling out pathology. So they're going to say, "Okay, I'm scheduling you for a colonoscopy and or an endoscopy." Right? So these are more invasive things, and it's not like they can't be valuable, but you can't define this kind of disorder that way. But they do those first to make sure there's nothing in a pathological vein. And then after they do that, then the doctor may, depending on his inclination, knowledge, and application of these things, start thinking that this is more functional in nature. Now, if the doctor is more hip, I'm going to say, then he will run something like a SIBO test. So, which actually would lead us to, how do you test for SIBO, right? So SIBO, the gold standard, even though there's some variances to it, is what's called the SIBO breath test, all right? So yes, you can have a couple of, a certain percentage of false negatives and false positives, but so be that in a lot of diagnostic testing, so you don't throw it out. And the 2 organizations in the gastrointestinal world that put out for their practitioners, the standards in which the field will employ, is going to be the North American Consensus and the Rome Consensus. And both of them do agree that doing the breath test is a non-invasive, accurate way of defining the disorder. And so what is occurring is that those bacterium that are now abnormally growing in volume in the small intestine, they're producing either hydrogen or methane gases, of which that is not something that you normally would produce much of. And so now, in order to define that, the breath test is performed by, if either it's done in the doctor's office, because it's going to take about 3 hours if you do it properly, or you can have test kits given to your patient, and then they can go home and perform it there after being instructed. So the test is performed where 24 hours before you do the test, you split that into 2 12-hour sections. The first 12 hours you're eating, but you have to eat non-fermentable foods. So basically you're eating things like some chicken, with salt and pepper, eggs, and white rice. Now, basically, for 12 hours, anybody can do that, right? And that will be the pre-diet. The second 12 hours is a fast, but you can A, drink water, and B, you're also including sleep. So it's not that many hours. It's not a suffering, to go through to get the test done. And then you begin the test on the second 12-hour period that is completed. And so you have these test tubes that have these little rubber stoppers on them, and you have a little mouthpiece that comes in the kit with an airbag that's attached to it and a little needle inside of it. So you push up the tube into that needle, you blow into it in a way that they instruct you to do it, and you pull it out. That's your baseline. And then there is a liquid called lactulose that comes in the kit, and you put it in some water and you drink it down. It's just a little sweet substance. But that lactulose is called a substrate. And that substrate is now going to be reacting with any bacteria that could potentially be overgrowing within the small intestine. So once you do the baseline test, then you drink the liquid, and then every 20 minutes, you're going to take another test tube and breath gas. And when you're finished, so it takes 3 hours to get through all 10 tubes. And at the end, you just pack it up, send it to the lab. They have sophisticated equipment in which they're analyzing for the concentration in parts per million of how much hydrogen and how much methane or none, right? And so speaking of that brings us to the next situation, which is, what are the different types of small intestinal bacterial overgrowth, right?
Subtypes.
And what are the presentations that are associated with it? So you have, they call it either SIBO C or IBS-C, you can call it SIBO M, right? So it's like SIBO C is constipation dominant, right? Or IBS-C is more constipation dominant. And that is associated with methane gas. And then you have SIBO D, or diarrhea dominant, and that is going to be hydrogen dominant. And then there are some people where the test shows that both are elevated in certain concentrations, and you have a mixed, so they call it SIBO M for mixed, all right, where people will typically have alternating bouts of constipation and diarrhea. And then more recently, there's been the emergence of a new form of SIBO called hydrogen sulfide SIBO. And this type of SIBO is, it is not directly evaluated with this test because they have yet to come out with a hydrogen sulfide diagnostic test, but there's a unique graph pattern that is present with hydrogen sulfide, along with very foul smelling gas and other symptoms. And so you put together both a clinical and that test result, and you pretty much know that the patient has a hydrogen sulfide type SIBO, and then you alter your treatment based upon the types of gas that are present. So there's no such thing as like, oh, I take this for SIBO or I take that. It's like you must define with these tests the types of gases that are associated with your particular condition, and then you know how to better approach the management.
Very informative. The testing is very extensive. It's getting more and more accurate. So here's my question. How do you get SIBO? How do you develop it?
Well, that's a good question. As a matter of fact, in my studies that I did with Dr. Jacobi, the one thing that she stressed so much, which was brilliant, I mean, it's a perfect functional medicine platform, was she said she has a paper that she wrote, and I put it on my website, and it says, like, how did I develop SIBO? Because she said it is just as important to figure out how people develop their problem as it is to define what they have, once they have SIBO, all right? Because it's going to give you an understanding of how long they might have had it, the chronicity associated with it, because a lot of people say, oh, IBS, I've had IBS for 100 years. Like, everybody is not just the acute one that comes in. It says, oh, you know, I did. So it does develop from, I think the good term would be impairments, okay, is the operative term. So you have motility impairments, because one of the things, and this is actually a really key point, is that when you develop SIBO of any of these variant types, what is transpiring from these excess gases that are forming from this bacterial overgrowth is that you're altering a part of your nervous system that lines your small intestine, known as the MMC, or the migrating motor complex. And as some doctors, like to help patients understand it, they call it the clean sweep. So when you don't eat for 90 minutes or longer, your migrating motor complex will actually turn on like a machine, and it will move the contents of whatever is lining your small intestine down the track. Now, that is both any food material and or bacteria that could be lining there. But that migrating motor complex becomes impaired due to the excess gases. And now you have a big problem. So now the food mass is like, it's staying there too long. And so you have a combination of fermentation. And this is why distension and bloating becomes so prevalent within this disorder from this mechanism. So that's one. Now, some people will develop alterations, and they develop SIBO because they had an acute food poisoning at one time. And so we've all, I think, depending on your age, but I think most people have had some form of food poisoning, unfortunately. But if you've had it and it was one of those 24 hours where you dumped and you vomited and you whatever, and then within 24 hours you're better, that's less likely to be problematic, okay? But there are people who develop food poisoning where it's quite significant, and it's there for days on end and they're ill. And one of the things that's interesting, Dr. Pimentel, who is the lead gastroenterologist researcher in the world on SIBO, figured out that some percentage of people develop SIBO by the interaction of having that acute infection, acute gastroenteritis that came from that food poisoning, and it altered, right, a substance on the lining of your gut and caused an impairment. And so he came up with a blood test called IBS Smart. And that particular test looks for what is called cytolethal distending toxin B and antivinculin. And these are antibodies that actually form within the intestinal lining. And so in talking about people who have like chronic SIBO and can't get rid of it, it's very interesting that it's primarily hydrogen dominant when they have this type, which means that it'd be more, it would be more diarrhea type, but yet you could have it both ways. It's no 100% of one as opposed to the other. But the reason why you would want to know that is because they have now termed that if that's the way it is developed, you actually have more of an autoimmune type SIBO, right? And these people have such alterations in their migrating motor complex that that they always need they may always need throughout life some what's called prokinetic or substance that's going to help stimulate the migrating motor complex and help moving things along the track. Because if you can't get that mechanism to kick back on, you're never going to win the war that's going on here. You're never going to win it. And so
So you got two types so far. You have motility with the migrating motor complex.
Right.
Cytolethal distending toxins, which you could consider autoimmunity.
Right.
I think there's two others.
And the vinculin.
Goes
together, right? And now you also can have impaired digestion can drive it, all right? So people who have low hydrochloric acid production in the stomach can be an initiator of the problem. You could have low pancreatic enzyme production. You can have poor bile flow, right? I know you're big on using bile acids to support certain you on that, but I will tell you that with using bile acids, the patients who have more constipation dominant should theoretically do better with the bile acids. Some patients who have hydrogen dominant SIBO, who have diarrhea, the bile acids can actually promote too much movement within the gut, because bile acids, even though they're the most alkaline substance there are, is a lubricant to the digestive tract. So it's like on one hand, you want to fix one aspect of it, but you got to be careful on the other. So I think you got to choose wisely with your patient population on that and see what works.
So number 3 was digestion. Number 4?
And 4 is going to be medications, right? Now, that's a biggie because, a certain percentage of our patients take narcotics, right? Like they're chronically on opioids or various narcotics for pain management, and narcotics will impair the motility in the gut. All right, so there's one that'll set the stage, right, for that. Like if you speak to people who live on opioids and you ask them, are you constipated? Almost all of them are. All right, so there's one. The big elephant in the room is proton pump inhibitors. Okay, now if you look at the prevalence of how much acid reflux and GERD and heartburn, as people call it, that prevails in our society, it's a pretty scary number. And now that the FDA many years ago said, hey, you don't have to go to your doctor now. You can just go to the pharmacy and you can buy the purple pills and all of these things. And because people are like, they got reflux all the time. And so between physicians who are the gastros, they're scoping people. They do see the irritation in the gut. And they go, okay, John, I'm going to put you on this medication that's going to suppress the acid. And they go, wow, this is great, doc. I feel so much better. And on one hand, it's the right first step for the management of a GERD scenario. The problem is that if you do nothing to resolve the underlying cause, the patient 3 months later gets off of the medication, the reflux comes back, and then they go back on it, and it ends up being a very chronic habitual use of the drug. And when you suppress the acid in the stomach in order to protect the esophagus from any erosion or reflux, while it's doing that job and doing it efficiently, you are now driving and creating a scenario where you've altered the pH of the stomach, which is necessary to be acid, and to now put that into the small intestine. As the food leaves the stomach, it goes into the small intestine, and it needs to be a certain pH. And if it's too alkaline, you're not triggering enzyme production, and you're letting bacterial growth come about.
So which is a problem, because remember, you said it wasn't pathogenic, it was too much bacteria. Right. Now, those are the 4 problems. There's some terms called SIFO, and LIBO. What are they? What is the acronym for?
So again, these are all the acronyms, right? So just to be clear, because people like to read these things who have gut problems, we said SIBO is small intestine bacterial overgrowth. SIFO is small intestine fungal overgrowth. And LIBO is large intestine bacterial overgrowth, just for nomenclature or a clarity on what they are. And they're all different. But here's what's really interesting. There's a researcher, a gastroenterologist, famous researcher. His name is Dr. Rao. I think it's R-A-O. He's an Indian doctor, very astute doctor, who, the only other way you can properly define SIBO, like with a direct analysis, is by doing what's called an aspirate from the small intestine, which means a gastroenterologist takes an endoscopy, goes down your throat, through the stomach, and he gets into the first portion of the small intestine, and he actually can sample some of the liquids from that proximal portion and pull them out and take them back up and grow them in the lab and go, okay, this is what's growing in this concentration, right? And because actually in the duodenum, which is the first part of the small intestine, they say that there should be zero amounts of bacteria of any kind growing in there, because the stomach acid that's normal is flowing right down into the first portion of the small intestine, and the acid is sufficient to kill off any bacteria that live there. So that shouldn't be there. But anyway, not to lose track here. He did this research study, and he took a couple of hundred patients that had bacterial aspirates, and he found that 24% of all the people that had SIBO also had SIFO, which is small intestine fungal overgrowth. So that's 25% of all patients.
It's a large amount.
Right? Now, what's really interesting as a clinician, once you understand that reality, is that you can have a patient that you have effectively managed their SIBO. And that's why you have to do follow-up breath tests. And then let's say you did, whether it's one full course of 6 weeks of therapy, ran the test, better but not perfect, you do some more, you did it, you do a second test, and now the SIBO test is negative, but the patient is still positive for symptoms.
Bingo.
Don't beat your head against the wall. It's most likely an underlying SIFO that is also present, because there's a tremendous overlap of symptoms of SIBO to SIFO. Tremendous. Like sometimes you can't differentiate between the two. As a matter of fact, if the patient has all the signs and symptoms of SIBO and you do a breath test and it's negative, it's SIFO.
Interesting.
See?
That's a new one. A lot of people won't know that. And LIBO is just large intestinal bacterial overgrowth. Now, is that too much bacteria, or is it?
Right. Now, LIBO is a whole nother ball of wax, okay? But it's just like if we keep moving down the intestinal tract.
Let's just give them a quick.
Now, LIBO is all of this is called, they are all different forms of what's called dysbiosis, right? Which means an imbalance within the ecosystem of the gastrointestinal tract of what's growing, the good guys, the bad guys, and so forth. But with LIBO, you have such a myriad of organisms and issues that can be present. It's outside the scope of this particular conversation. We need to understand that there are times when that overgrowth in the large intestine can be so prevalent that it is a contributing factor to what is happening up higher in the small intestine. And so you're getting what's called LIBO contributions to SIBO, because you have so much overgrowth of organisms down below that they have no choice but to start to spread out and become problematic.
So you've done a great job of giving good dissertation on the differences, especially, but I guess you're right. So we're running down on time. So let's stick to SIBO. How would you treat SIBO?
Okay. So SIBO, there's three pathways to treatment. Let's just cover pharmaceuticals for a second, because they are a viable option for people. Even though we personally, don't prescribe them, but physicians do. There's a drug called rifaximin, also called Xifaxan. One is the generic term. So Xifaxan or rifaximin is the antibiotic that is effective for the management of SIBO. Now, when a patient has hydrogen-dominant SIBO only, a course of rifaximin, 550 milligrams 3 times a day is the standard for 2 weeks. If they have methane dominant, then rifaximin with the addition of neomycin is the standard that is employed for that. But I do want to make one statement here, because a lot of people get crazy with like, no, I don't want to, look, I got this bacterial problem. Now you want to give me antibiotics, doctor, and so forth. Rifaximin is not really systemically absorbed. It works locally in the gut. It's actually not a harmful bacteria the way antibiotic, the way a lot of other antibiotics are. So they do need to be differentiated here. And even the neomycin, which is a standard antibiotic for methane that goes with it, the rifaximin actually protects the gut against the negative effects of the neomycin in research studies, that it doesn't just wipe out, all the good flora. So that's the standard medical approach for this, okay? But as you study SIBO and you get deeper into this, you realize that for probably 80% of cases, just a standard treatment of using the antimicrobials like that are, they can work if you have an easy case, but the need for repeat utilization of them and not looking at all the other things that could be going around it is short-sighted, okay? But anyway, that's the standard medical approach, and it is effective for a certain percentage of people, so it's good. In our world, we use botanical medicines, all right? And so, again, depending on whether it's hydrogen dominant, methane dominant, hydrogen sulfide dominant, there's different approaches. And so there have been a lot of different botanicals, and some of them, for instance, like on hydrogen dominance, berberine is a very important agent. It has phenomenal properties, and it does lower the volume of concentration. It does kill off the organism. So it is an antimicrobial. Then there's there's oil of oregano, but not taken as a liquid. It's too caustic. People who buy the liquids and try to get it in, they end up getting burning their esophagus. So I don't recommend it. There is a form that you and I both use that's in a pill form. It's both emulsified and time released, which is perfect because it's slowly disseminating throughout the tract as it goes down. And it does a heck of a job of helping eradicate the overgrowth. And then there are formulas. So, there are different professional nutrition companies out there who have put together good formulations to assist with this, and they are highly effective. So much so that my good friend, Dr. Gerrard Mullin, gastroenterologist at Johns Hopkins, published a research paper on the efficacy of the botanical approach versus rifaximin, and found it to be equivocal, if not better. So for any of those naysayers or think that it only has to be derived through an antibiotic, the answer is you can effectively manage it with the correct botanicals, with the correct diagnostic procedures, and all the other associated nutrients that you might use, right? Which we could expand this, but we don't have the time, and that's not the nature. It's to help people understand more about what this condition is, and that there are answers for its management.
Excellent. And those are the best ways to treat. You got your drug, you got your botanicals.
Oh yeah, and then there's the third. The third way is I've never used as a sole modality, but the research so far does show the efficacy, which is a diet called the elemental diet. And the elemental diet, it's only made by, I think, like 2 companies, in which they've taken, it's a food replacement diet, of which you take a certain period of time, a couple of weeks, and you don't consume anything except the elemental diet. Now, there are some variances to that approach, but everything is broken down. It's pre-digested. So when you look like on the label and you go, where's the protein in there? How am I going to live on this? It's all the amino acids that are present for proteins, and so it's there. And the types of bacteria, the types of carbohydrates and fats, everything is pre-digested, ready to go in a pleasant flavored powder. And depending upon the weight of the patient, like their height and their weight, is a table and calculation, and you figure out how much they need to consume a day. And by not having any of the foods that could cause the bacteria to grow, which we call that a substrate, like is the food substance that would interact with that bacteria, by not having it present, the body can do its own thing, and it helps begin to you take the food source away from these organisms from growing, and they stop growing. So but most people, it's an expensive way, but it does work. And then there's a modified way to use the elemental diet, in which, like, even if you had them do it for half a day and then they eat the right foods. But the other thing that's really important is that there are specific diets associated with the management of SIBO. And so these diets come under the heading of what's called a FODMAP diet. And here we go with the acronym again, right? So the F stands for fermentable, right? And then the OD is oligosaccharides, disaccharides, and so forth, and polyols at the end, which are sugar alcohols. So here's another tip. Like, some people will say, I don't want to eat a lot of sugar, and I went and I bought these power bars that they sell everywhere, and it has, it has sugar alcohol. So what are they like? You see xylitol, mannitol, and all these OLs at the end of it. If you don't recognize it, but you see an OL at the end, that's the sugar alcohol. And you say you eat that and you don't feel good, or you bloat, or you actually even got diarrhea from it. That can be an indication that you might have SIBO. All right. So it's pretty common. They use that everywhere now.
How's that compliance with that FODMAP?
Well, the FODMAP, is not the easiest diet in the world. It's restrictive. Now, Dr. Jacobi, she came up with what's called the SIBO biphasic diet, right? This was the original FODMAP diet, understand, was made to find out all the foods that interact with that bacteria and which ones cause you to bloat and have symptoms, and which ones are more tolerant. It was developed in Monash University in Australia. That's where it came from. And then people like her, who was a specialist in this for so many years, she knew that more needed to be done because it worked for some, not all. And she created the initial SIBO biphasic diet, in which she says for the first 1 to 2 weeks, you really should be eating a very restrictive FODMAP diet. And by doing so, it's not curing the disorder, but it decreases symptoms significantly. So even though you can say that it's challenging for people to eat such a restrictive diet, if you're gut and you're bloating constantly, or you can't go to the bathroom, or you're going all the time and you have pain and bloating and distension, and every time you eat, it's like, hey, it's like one of those things. Then, well, how motivated is the patient to want to be better, right? I mean, you just got to lay it on the line. Say, this is going to be challenging, but you're going to feel better if you follow it. If you cheat, you're also going to feel it. So it's up to you. Now, it's not going to cure your disorder, but it's going to manage your symptoms, right? So that's the purpose of the diet. However, she then went on, being the specialist that she is, and a thinking functional medicine person, she's a naturopath, all right? And she said, wait a minute, what about if a vegetarian comes in? Because the regular biphasic diet has a lot of proteins, because when you look at the restriction list, you can't eat, you know, all these fermentable foods. But the one thing that doesn't seem to ferment, right, is eating chicken and fish and turkey and meat and so forth. So the proteins can be abundant. But then what do you do with a vegetarian, right? They're SOL, right? So, you know, so she worked really hard with another nutritionist, and she came up with the SIBO vegetarian biphasic diet, in which you're sprouting particular beans and things, and that would be low FODMAP, and she came up with that. And then you have another subset of people that have histamine intolerances. And those people eat certain foods that could be FODMAP friendly, but they're still getting reactions, and they're getting histamine reactions, and they're flushing, and they're so forth. And actually, it's a decent subset of people. So then she worked on that, and she created the SIBO biphasic histamine diet, in which she removed histamine liberating foods. And those are the three basics. But what's interesting is that even people who have methane dominant SIBO, which is constipation, some of them do not have enough vegetable matter in the standard SIBO biphasic diet. And that's not healthy either, like for any prolonged period of time. And she actually puts some of the methane patients on the vegetarian diet to increase the amount of fibers that are tolerable within the diet, okay? And that's another really important point, because a lot of people who are constipated say, hey, take fiber, go to the store, buy psyllium, buy this, buy that. Fibers for SIBO patients are very challenging. They could bloat more from fiber within their diet because it can ferment and cause a reaction. The only fiber that seems to be, let's call it FODMAP friendly, SIBO friendly, or gut friendly for most patients is called partially hydrolyzed guar gum, or PHGG. That is the only one. So that's a good tip for those people. But again, you need to start slow. And if it says take 2 scoops a day, no, start with 1/4 of a scoop a day and slowly build up as you go. If you get to a point where there's any bloating, go back down and wait until you can slowly advance and do that. But partially hydrolyzed guar gum, the more I study it, I'm going to nickname it, it's the bomb. It's the bomb because it provides prebiotics, right? Substances that help the good bacteria grow. And one of the things in the world of studying the microbiome, which is clearly the most important thing, like in the 21st century, like now what we're learning, and how all these organisms in our gut are not just this biomass sitting there, but they're amazing how they're signaling molecules, and they're talking to the whole body and telling everything what to do. And as the researchers prove this point, it's getting stronger and stronger every day. So one of the things that they have figured out so far is that within that large intestine, 100 billion or more organisms, there must be diversity to that biomass of organisms. When we start losing populations of various organisms, we're not just lowering the volume, we're lowering our resilience as a human being for our survival. That's how important diversity of bacteria needs to be within the large intestine. And so when we eat various vegetables and salads, right, more of a plant-based part of our diet, we're providing prebiotic fibers in those various foods as these substrates to feed those healthy bacteria and keep us going. and keep us resilient and healthy. So living on FODMAP diets long-term are not smart. They're designed for the management of symptoms of SIBO, not to be long-term. But just like PPIs can get abused in regular medicine for reflux disease, FODMAP diets, people get scared to go forward and add more foods after they got better, and they live on them, and then they're restricting the growth of healthy diversity within the gut.
Microbiome, 80% of our immune cells at its core, where our micro and macronutrients are absorbed. Biodiversity, superpower of our health. Real quick, why do so many people have a relapse in SIBO?
Good question. I think that the answer to that is that it's a diverse question, because that's the reason why you want to find out how they got it. Okay, so I have a form on my website that says, you know, how did I get this, right? And they fill it out so that they can see the various causes, but you as a clinician want to look at that. So you have a certain set of people that are diabetics, for instance, and diabetics have notorious motility issues within the gut because they develop enteropathies, right? And neuropathies and enteropathies. Enteropathy is going to be in the gut, you know? And so that there's a biggie. And look how many people are pre-diabetic and diabetic, right? So they got high sugars and they have all of these problems. Then you have people who've had surgical interventions, and you want to know that. Did they have their appendix out? Did they have their gallbladder cut out? Have they had any direct surgery? Did they have a resection within there? They have diverticulitis. Then they had to cut out a section, anastomose it, and now there's scar tissue that forms. So these are impairments in outflow, is what we call it. Okay, and so now there's a physical reason for restriction within the intestinal lumen that's not allowing things to move. Okay, you have in a small percentage of people, you have people who have dysautonomia, right, where they have conditions like POTS, postural orthostatic hypertension. You have Ehlers-Danlos syndrome, which is an autoimmune of hyperflexibility within the body. Things of this nature. So again, you got to dig deeper. You got to take a really solid history. You got to look at how they formed it. What are the drugs that they keep taking? Like, you could manage it, and then they keep taking antibiotics and they're taking proton pump inhibitors. So, or they go on them and off them and on them and off them, you're going to get recurrences. All right. This is the reason why I believe that the current statistic is that 11.3% of the world population has this disorder of SIBO, which equates to 500 million cases worldwide. And unfortunately, that number is escalating because of these various etiologies behind its development.
So 11.3% of the people in the world probably have SIBO.
Correct. And that's a conservative estimate. That just shows you how many people have digestive issues of this nature. And this has nothing to do with, IBD or irritable bowel disease, in which you're looking at, Crohn's disease and ulcerative colitis and things of that nature. We're talking about functional gastrointestinal disorders. So if we took 100 people on the street and we just stood up there and people were willing to be honest and talk to you, you'd be, do you suffer from constipation, diarrhea, or bloating? You would be surprised at how many people live with it. But of course, degrees. How many people have it, live with it, don't manage it at all? I mean, I was sitting at a family dinner a couple of months ago, and my cousin's sister, they said to me, I get this, and I said, you have IBS, it sounds like. And she says, yeah, if I eat this, I run to the toilet all the time. And I said, well, did you ever get tested for this? And she said, yeah, the doctor told me to do something like that, but I don't want to change my diet. And I said, right. So meanwhile, she's got a chronic GI condition, right? But the problem is that one thing is the discomfort associated. The second thing is that after you have it for a really long period of time and it's protracted and you haven't done anything to resolve it, or the doctor wasn't good enough to help you understand it, you know, all your fat soluble vitamins will start to become depleted. All right, so then now you have a whole nother ball of wax going on, right? And another interesting point of view would be, you see a low iron level on a blood chemistry, and the patient, you've already ruled out that they're not bleeding from anywhere, and depending on the age of the patient, male or female, and as long as they're not menstruating excessively, where would the blood loss be coming from, or the iron loss that could be contributing to that? And the interesting thing is that the research has found that when people have a longer-term SIBO, it sequesters the iron and keeps it away, all right, because the bacteria want to use it. So a low ferritin level, which is a stored iron level, can be an indicator in people, right?
Interesting. I wrote it down. I mean, I got a lot to share with everybody when I write the synopsis of what's going on. Without question, you gave a panacea of information pertaining to SIBO and all the others. You know, honestly, we need to do this again, and we need to branch off into some different things, because I know I'm going to get a lot of feedback, and people are going to really want to know how to test and treat, because that's what everybody who listens wants to do.
I'd be happy to. You know, we all have to share. You know, like,
we all have to share. That's right. This is great.
Knowledge is only as good as what you do with it.
That's right. You know, because knowledge plus action equals power.
That's it.
There you go. So, Dr. Marks, Loren, it's been great. We got to do it again.
My pleasure.
Fascinating dissertation on SIBO. Dr. Rob, Proven Health Alternatives.